instead of retreat.
Work
The
camp?
the work camp, leadership work.
Yes, that's it. Um, to essentially return and report and let you guys know how the new BSM program is going. So what we're going to do is I'm going to turn some time over to Sarah to go over some of the intricate details, and then we're going to give you some results on how things are going. So, Sarah.
Sure. So, um, as you probably all remember from a couple of years ago, when the new MEET competencies came out, we looked at them as a holistic advancement in our program. They are more in depth in quite a few areas, and they really called for a more explicit linking of academic theory learning and clinical skill and performance learning. So when we designed the new BSM program to meet these competencies and guidelines, we put a strong emphasis on connecting theory to practice, connecting academics and clinical. And we did that through the phased program, and we also included the integrated assessments to really help students integrate the learning they were doing in the classroom, in the virtual classroom, and in their clinical work. So, excuse me. So the way the program is now set up, and this is what students have been enrolling in since September of 2016. Students who are in the previous program continue with their program. Nothing has changed for them with regards to this. This is just what new students have been beginning. So we're kind of rolling it out as the students advance. So they will start with their phase 1 classes. This includes basic biology and medical terminology and midwife's assisting. The classes that students need to know before they get into some of the others. It also includes some of their general ed classes, things like writing for midwives, communication, so that they have those basic skills and are ready to succeed in the rest of their academics and school career, as well as clinical. While they are doing those academic phase 1 classes, they're also doing their observe experiences, and we have a competency class that helps them in learning the skills to be a birth assistant, the very basic skills like taking vital signs, charting, things like that. And they complete those during, give or take, their first year. I refer to it as their first year, but of course it's a flexible program. So for some students that may be 2 semesters, for some it may be 4 or 5 semesters. But when they finish their phase 1 classes, they take their phase 1 assessment. And the integrated assessment is more than a clinical thing. It is intended to explicitly link and give students a chance to link their academic learning with their clinical skills. So for example, we might have them actually practice taking vitals on a model client and charting that information while they're also educating a client about the phases of labor, something they've learned in their classes. Oh, I've just muted myself. I'm sorry about that.
No,
I bumped
we
my.
can hear you. I
Okay,
can hear you.
Oh good. I bumped my little thingy on my headset. And we'll go more into what the assessments look like and how they've been working, because we have had a chance to do those with our students. But as students move through the program a little further, they take their phase 2 classes, which are what we call healthy pregnancy, healthy labor and birth, healthy postpartum, well person care, all of those what we have called in the past core midwifery classes. Most of them are there. And while they're doing this, they're also in a clinical practicum class to help them get the most out of their assist experiences, where they're in a preceptorship, they're assisting a midwife, and they're learning the skills that will enable them to be a primary midwife. At the end of phase 2, there's another assessment. This is more advanced. Of course, we're expecting students to be able to take the knowledge and skills that they've gained over probably 2 years of work and show that they're ready to act in the primary role under supervision, and that they understand the basics of midwifery care. Then they move into their phase 3 classes. These are advanced and complications. So these are the non-typical things that we see as midwives. Breech and hemorrhage, things that we need to be prepared for, but are not usual. And they get into more of the in-depth theory, nutrition classes. I'm having trouble coming up with some of the others. But phase 3 tends to be a little bit lighter on the academics. They are taking classes, they're taking these more advanced classes, things like genetics, but they're also spending a fair amount of time doing their primary under supervision and continuity of care experiences as a primary midwife under supervision. This is a chance for them to practice and learn their advanced skills, the ones that they may not have to use every day, but they need to make sure they're ready for. And of course, they don't appear on this chart, but there are classes and experiences that are flexible, that the students can take at any time. Some of them are electives, and some of them are just flexible classes that we feel can be taken and well used, whether they're beginners or advanced students. At the end of their phase 3 experiences and their classwork, they can take their final assessment. This will be, a lot of sorting through scenarios, talking about their theoretical understanding and asking them to move beyond understanding and applying knowledge and into actually evaluating knowledge and asking questions of themselves and of their community. After their final assessment, they are ready to graduate and take the NARM exam and move into being a functioning CPM and hopefully midwife in their community. Can you flip the slide for me?
Got it.
Thanks. So the integrated assessments are held at the end of phase 1, phase 2, and phase 3. And they have the same basic format, but of course the material becomes more advanced as the students advance. The 4 kind of test portions of the integrated assessment are a written exam. This is done in the same format that the NARM exam will be in, so multiple choice written questions taken online now. They have skill scenarios where we ask them not only to perform skills in isolation, but to actually work through scenarios. So rather than just, perform bladder catheterization on this model, we might say, this client is showing signs of hemorrhage. Here are the signs. How will you proceed? And asking them to explain how they are choosing their course of treatment or course of action, and then enact that. There's also a client education and shared decision-making portion. Because this is such a crucial skill and very jugular to the new competencies, we wanted this to be its own portion of the integrated assessment. So for the client education portion, students will actually work with a model client and educate them on some topic. And they will have the chance to do shared decision-making processes. More than informed consent, this is going into what does the client need to know about this decision? What kind of support do they have for making their decision? What kind of support can they expect from the midwife? And how can you, the student, as a care practitioner, really honor the sovereignty and decision-making autonomy of clients? So it brings in a lot of the communication skills, health education skills, and cultural awareness and respect skills into real life. So it's not just write an essay about this, tell us what you think, or here's a client situation, good luck. It's really explicitly asking them to think about and prepare for those situations that midwives handle every day. The final part of the integrated assessment is the oral exam. This is, again, a chance for them to tell us what they think. So they'll be given a theoretical question and asked to prepare for it and discuss it with us. And then the integrated assessment ends with an interview. Do you want to flip to the next screen? Because I think I'm saying things that appear on that slide.
I was just going to let you keep going.
Thanks, Mariah. Just let me talk. The interview is not an assessment so much as it is a chance for the student to reflect on what they have learned in preparing for and accomplishing this assessment, do some self-reflection and feedback, and they receive the feedback from the assessors on what we or those assessors have seen during the day of assessment. The point of this is to give students really robust feedback that is specific to the particular skills or knowledge base that they are showing, and also holistic, that it's not just, well, you missed 15 on the written exam, better study. It's, we noticed that you had particular trouble with the written exam in the breastfeeding section, which is interesting because when you did your client education portion, teaching a client about breastfeeding, you did very well. So let's figure out what is difficult for you. Is it the multiple choice format? Is it the more theoretical aspects versus the practical of breastfeeding? You know, and we could really get into what the student needs at that point and how we as a school can help them move forward.
Go forward.
Yeah, please.
Okay. So one of the ways that we are able to give that very specific feedback is that as a department and heavily in the integrated assessment is we have Sarah's brainchild. We evaluate based on this exact rubric in pretty much all the assignments and the integrated assessment. What we're looking for is competent. But we also have the rubric level of exemplary, which would be not them demonstrating like years ahead, but that when we evaluate them at phase one, competent is that they are at the place in their development as a midwife that we would expect the student to be at phase one. We're not expecting them to be all the way at graduation level at phase one. If they get competent at phase one, that's where we expect them to be at that point. The rubrics actually delineate for the assessors in the integrated assessment what we are exactly looking for in the skill scenarios, in the client education, so that we can drill down and give that exact feedback. We have a couple of students that have gotten exemplary, but almost all come out at competent. A couple come at developing, and that just lets us know that they're developing the skill, but they're not quite there yet. The other interesting thing is we no longer have work out of the PSGM. We have utilized the Birthwise Skills Guide, and we have inventory forms on their skills with this exact rubric. So when the students are in practicum classes, they are getting evaluated each semester on where they are with their skills based on this rubric, so they can see, oh, I've just been learning this skill. or I haven't even started touching this skill this semester. Next semester, I need to set a goal, which is what we have them do, to start working on a particular skill that they haven't been exposed to yet. And we have them meet with their preceptors to make those goals and decisions when they're filling out the rubric for their skills at each semester. So, Sarah, do you want to cover this one?
Sure.
Okay.
So we have done four cycles of our phase 1 integrated assessment. And when I say cycles, they have a competency class that they are enrolled in the semester before they take the assessment. So for us, for Mariah and I, we work with the students for a semester leading up to the assessment. So it's not just they show up one day, we assess them, goodbye. No. They know quite a bit about what to expect when they come to the assessment, and we want them to be very well prepared and feel like this is a challenge they are ready for. So as I said, this is with students who enrolled starting September 2016. So it's sort of slowly ramping up. In those 4 cycles, we've assessed 14 students total. 12 have passed with competent or exemplary in all areas. We had 1 who had remediation. That means that that student was competent in most areas, but had 1 or 2 areas where they needed help. They were developing. And so we worked with that student, and that student is moved into phase 2. And then we did have 1 student who is preparing for reassessment. That is that student was developing in several areas, and so needs to go back and fill some gaps before being reassessed and moving forward with their program. So they're doing some preparation for reassessment and working on electives and some other things so that they continue to move forward, at least credit-wise, while they're making sure. And I have to say, it was of course very concerning the first time we had a student not pass. As a teacher, that's almost as alarming as it is for the student. But what we found was that these assessments are tools for identifying needs, and that it was actually a really wonderful thing to find out at the end of the first year where students might be struggling, so that we can help both those specific students, and also if we find something that, wow, several students are having trouble in this area, then it gives us a chance to address that. As a whole school, or as a particular class, or wherever it needs to be addressed. It's been really helpful in helping us know how to help students move through the program. Kind of coming back to this idea of enabling constraints, it may seem like, well, gosh, you're putting this thing that the students have to do, and that must be difficult. It is challenging for students. And yet, the students who move through it enthusiastically tell other students, this was a powerful experience for me. This was something that I came out of saying, now I know that I need to move forward with this. Jennifer's asking, did it seem like it was a preceptor issue, training, classwork? The students that needed reassessment or remediation?
Can we,
because it's so specific, I don't feel like I should give real specific details, but I can tell you that it was, in both cases, it was more than one thing.
Yes.
It was a combination of factors, and I'm very glad we caught it when we did, because because it's very important to me that our students have the tools they need to move through the program successfully. And we know that end of the first year or about second or third trimester is when we lose students in large numbers. I'm assuming, Christy, that the board has seen the same trends that we were shown. Anyhow, second or third trimester is, if we're going to have a student drop out, that is the most common time. And so this is positioned in such a place that it allows us to sometimes find those students and say, this student is at risk.
I would wholeheartedly concur with that, Sarah. I can't see the chat, so I don't know what's coming through.
Valerie is asking, to be sure I understand, students in phase 1 are basically in their observe phase. Yes. So they're doing their observe experiences, and they have a practicum class for that as well. And they're doing their basic general ed and kind of preclinical classes. So anatomy and physiology and things like that.
Okay, sorry, I didn't mean to interrupt you. I was just going to clarify. So these students in phase 1, most of them are not already with a preceptor yet.
Actually, what we've found is about half of them have done some work, usually informally, with preceptors. Sometimes they've been working with preceptors for years, and sometimes they are completely green. They've never worked with a preceptor before. Our clinical goal for these students is for them to show competency, that is basic ability to do some of these basic skills, taking vital signs, providing labor support, charting, those very basic things, so that when they move into phase 2, they'll be ready to hit the ground running and really learn midwifery rather than learning how to be an assistant as an assistant. Does that make sense, Valerie?
Yes, thank you very much.
Sure.
Yeah, I didn't mean to interrupt before you were finished with your program. When you're finished with your presentation, I'll probably have some more questions.
Oh, we're
almost there. Yeah.
So it's question time. So throw them out, Val.
Okay, so since students start by the way, I think this is wonderful. I'm really excited about what I'm seeing here. This is great. But since students come into the program at various stages, so I assume that people coming into MCU, some of them have zero experience whatsoever, and others maybe have attended many births as an assistant before they even start, right?
Yeah,
that is correct.
Oh, right. So when they're going through this clinical program here that you've just outlined, so they have to pass off the phase 1 skills before they can count any of their numbers to be as an assistant. Is that correct?
Would you like
Not
me to
exactly,
answer this one, Sarah?
Actually, Mariah, will you take us back to the big slide, the big picture slide?
The beautiful one that you did. So
sure.
Okay.
So there's two things, Val. We do have an exception policy that allows students who do come in with considerable clinical work already under their belt to start their phase 2 experiences early.
Okay.
But we don't count them until they have passed this phase 1 assessment.
So
we allow them to start accumulating them early, but we don't count them until they've passed this, because this is the mark that they have not only done the clinical aspects of it, but also learned the academic knowledge, so that they are integrating these skills. Because as you know, you can do births and do clinical and then go back and learn the things that you need to know about that. And it doesn't have the same effect. You don't learn things the same way when you're not learning them and integrating them together. Does that make sense? So that's what we're trying to encourage and move students toward. The other thing with having students start their clinical work, their clinical placement, their assist experiences early, is that that usually means that they finish them early. And the problem there is then they are wanting to start their primary experiences and they haven't completed their phase 2 classes and skills. So we do
Right.
try to encourage students. It's difficult. No one comes to midwifery school because they love studying biology. At least no one I've met. They come to midwifery school because they want to catch babies. They want to have their hands on bellies. They want to be working with clients. It's a normal thing. And what we're trying to do with this is to guide students into integrating and doing both together, learning the academic knowledge and learning it while they're doing the clinical experiences so that they can integrate that knowledge. They can go to class on Monday and learn about HELLP syndrome, and they can be in clinic Tuesday looking at a client with high blood pressure and thinking, maybe we should take liver enzymes. Perhaps we should work, maybe we should do a platelet count. Because they're learning those things and being able to put those things together, that is the ideal for the kind of education we want to provide.
Great. I would suspect that one of the challenges you have here with this is that the great variation in pace depending on where their clinical placement is. They may be in a busy birth center where they're getting things rapidly, and they may be with a solo midwife who does not have so many clients, and so you're dealing with people who are in different phases, but they're getting different amounts of experience, different types of experience.
Yes. Well, and that's a universal struggle of midwifery education, right? This kind of puts a frame around it so that we can see it more clearly. We can see then when we have a student who isn't doing her phase 2 classes because she's in clinic 5 days a week. And she's almost finished with her assistant experiences, but she has 3 more semesters worth of academics. And we can see that at that point and talk with her about it then and say, okay, what are we going to do about this? Because it's great. You're getting these wonderful clinical opportunities and you also need to finish your academics. How are we going to do this? And we can do that before she has completed all of her clinical experiences and is looking at 2 years of academics that she hasn't done and hasn't integrated. It does. And because of that, we have some tools built into the curriculum. The clinical practicum classes that they do, let them know how many hours they should be spending in clinical. And if they're doing lots of clinical hours, then they should be doing less academics that semester, with the understanding that they have to get the clinical experiences and hours and learning, and get the academics before they can move forward. It is challenging in some cases. It's also providing a framework for students to start thinking critically about their clinical placements. And it is addressing in some ways this the scarcity mentality about clinical experiences, because students have realistic expectations. And rather than feeling like, well, I have to take any clinical opportunity that comes my way, even if it is out of sync with my life, even if it is borderline abusive, instead they say, I need to do these classes, and I need to do this amount of clinical, and how can I arrange that? And frankly, it's less the students that are having concerns about this and more the preceptors.
Mhm.
because it's no longer this wide open, take a student and just have them work for you until someday they say, I've done enough and now I will take the NARM.
It's a
Mhm.
complete paradigm shift for the preceptors, very much so.
Mm-hmm. Yep.
So then I would suspect that one of the really critical things about this is that this is all really laid out clearly to the new students. I assume you've done this. So they understand that it's going to be like this, and they understand the ramifications, which means,
Mhm.
for example, I mean, I know I have had a lot of students, and I know how they think. Some are MCU students and some are not. And they're thinking, I want to go to that birth. I want to get to that birth because look, I've only got this many more births, and then I can be in the next phase. But you're saying MCU students have got to look at it differently and say it's not just the births to get into the next phase. It's this the
It's the knowledge and the skills and the classes and putting it all together. Yeah.
and that's actually challenging for preceptors. I'm speaking as a preceptor because there's already a fair amount of coordination that goes on when you've got students in different programs, which most preceptors would, I imagine. And you know, you're trying to balance it out. So this is what I'm saying, I guess, is this is going to need a fair amount of interface with the preceptors so they understand how this goes.
Yes. And
So-
it is something, oh, go ahead.
I'm done.
Oh, okay. So Val, one of the things that we instituted last semester and we continued this semester, we have had preceptor, not just the preceptor review meetings
Mhm.
that go on monthly, but Jenny has also been doing preceptor orientation 3 times a semester for the new preceptors who are coming on, and they get sent out to the entire preceptor list to come and explain these differences so that they can understand how this program is different from what they may have previously experienced with MCU.
Mhm.
Or with other
So-
program, like you say.
Or or another program. Or
It is
PATH, or
very
whatever.
different, yeah, from some of the other programs. Yeah, the orientation is done semesterly for all preceptors, and they don't have to be new to come to orientation. I think it's usually half and half, new
Mhm.
preceptors and established preceptors who just want an update or don't remember things. We do our best to get them to come. Generally, they come when they have questions. Which is why Jenny's position as preceptor liaison is so important. She is available to answer those questions and help preceptors understand better what is going on with their students, why their students are sometimes saying, I really need to study. But it's also, we've had great responses from preceptors once they understand what's happening.
Mhm.
Often they will call and say, I don't understand, my student says she needs time off from clinic to study. What are you doing? And so we try to make those connections, talking about the same stuff we're talking about here, so that they understand better. We're not just trying to get them from point A to point B. We're working to create midwives of excellence. And seeing that vision, seeing the big picture, it all makes sense. Yeah, Valerie, I know that they're recorded so you can watch them, but
Oh, I didn't know that.
yeah. If you wanted to drop a line to Jenny and ask her if she might be able to do one in an evening or on a weekend or something like that. I don't know if that's available, but I know
Mhm.
she would consider it. She's always
Well, this
looking
is-
for ways to make those more available.
Sure, I appreciate that. And you can't please everybody, that's for sure. I mean, I know that. And it's not like midwives have schedules, but
There's that too.
I suspect, and this may simply be me, you know, maybe all the other preceptors got it, and maybe I just didn't. But it might have been helpful if somebody hit me upside the head with a brick and said, look, you need this orientation because our new clinical program is completely different from everything you've dealt with, and you're going to need to understand how it works for your MCU students. I don't know.
Yeah, that's what the approval of application for preceptor is
Yeah,
meant to say.
probably.
Maybe worded more strongly.
No, my problem is I was approved as a
Well,
preceptor years
yeah.
ago.
It's not just you. It is working with preceptors